Bismillah ar-Rahman ar-Rahim. This is Professor Abdussalam Yassin Taha from the College of Medicine, University of Sulaimani, giving a talk on one lung ventilation via double lumen endotracheal tubes. You can watch this lecture and other lectures by visiting the URL at the bottom of the slide. Lung isolation is a topic of great interest to both thoracic anesthetists and thoracic surgeons. The learning objectives of this lecture are to learn the evolution of endotracheal intubation and the rationale for one lung ventilation, describe the specific indications for one lung ventilation in adults, enumerate the different techniques for lung isolation, describe the modern double lumen endotracheal tubes, and figure out the differences between the right and left double lumen tubes, choose and position correctly a double lumen tube to achieve lung isolation, identify the problems related to the use of double lumen tubes in adults, and take home appropriate messages at the end of the lecture. History. Prior to the invention of endotracheal tubes, opening of the chest, that is thoracotomy, was almost fatal due to the collapse of the ipsilateral lung and tension pneumothorax. Subsequently, endotracheal intubation and positive pressure ventilation enabled the safe performance of thoracotomy and different intrathoracic procedures. The regular or the standard endotracheal tube has a single tracheal cuff and a single lumen, allowing ventilation of both lungs. So thoracotomy prior to endotracheal intubation was like that. When we look at this picture, when the chest is intact, both lungs expand during inspiration and decrease in size during expiration. When there is an opening in the chest wall, like in thoracotomy, the ipsilateral lung is collapsed, and subsequently there is a pendolic movement of air from the collapsed lung to the opposite lung, resulting in a series of changes such as hypoxia and hypercapnia, which eventually results in death of the patient. The regular endotracheal tubes were introduced in 1928 when an endotracheal tube was designed with a removable cuff. And here you can see the standard endotracheal tube with a cuff that can be inflated and deflated. And that is the modern single lumen tube, which enables ventilation of both lungs. So if we compare the bilateral lung ventilation with the one lung ventilation, in most patients requiring mechanical ventilation, both lungs are inflated and deflated together. This bilateral lung ventilation is usually achieved by the insertion of a regular single lumen endotracheal tube. One lung ventilation refers to mechanical separation of the two lungs to allow ventilation of only one lung while the other lung is compressed by the surgeon or allowed to passively deflate. Rationale for one lung ventilation. The use of one lung ventilation aims at facilitating surgical exposure by deflating the operative lung and providing selective ventilation, as well as preventing infection or secretions from entering the healthy lung. The shared responsibility. Many thoracic surgical procedures can be safely performed using a single lumen endotracheal tube. On the other hand, many thoracic operations require one lung ventilation. Therefore, ideally, every thoracic anesthetist should be well trained in lung isolation techniques. This doesn't exclude the potential complications of one lung ventilation in some patients' subgroups. Hence, the decision should be taken by both the operating surgeon and the anesthetist. The latter should also be competent in managing the problems that emerge during one lung ventilation. The indications for one lung ventilation can be divided into absolute indications and relative indications. The absolute indications include, number one, to prevent damage or contamination of the healthy lung, such as in lung abscess and pulmonary hemorrhage. Number two, to control distribution of ventilation, such as in bronchopleural fistula, major cyst or bulla, and traumatic bronchial disruption. Number three, to facilitate single lung lavage in some diseases such as cystic fibrosis and pulmonary alveolar proteinosis. The relative indication for one lung ventilation is to improve surgical access, which can be a strong indication or a weaker indication. The strong need for improving the surgical access is encountered in thoracic aortic aneurysm, pneumonectomy, lung volume reduction surgery, minimally invasive cardiac surgery, upper lobectomy, and video-assisted thoracoscopic surgery. While the weaker need for improving the surgical access is encountered in esophageal surgery, middle and lower lobectomy, and mediastinal mass reduction. Techniques available for one lung ventilation. There are three different methods that can be used to achieve one lung isolation and one lung ventilation. Number one, the double lumen endotracheal tubes. Number two, bronchial blockers. Number three, a single lumen tube advanced into either the right or left mainstem bronchus. Each of these devices have their own advantages and disadvantages. In the present lecture, we are going to concentrate on the double lumen endotracheal tubes. So the introduction of the Carlin's design of double lumen tube in the 1950s was a landmark event in the practice of thoracic anesthesia worldwide, as it allowed anesthetists for the first time to reliably achieve lung isolation. So in this picture, we can see the Carlin's tube, which is characterized by a carinal hook that is designed to prevent dislodgement of the double lumen tube. And in this picture, we can see the Robert Shaw double lumen tube, which is made of red rubber, and it comes in 3 sizes: small, medium, and large, and can be also of 2 sides: the right-sided double lumen Robert Shaw tube and the left-sided Robert Shaw double lumen tube. Several decades later, and after multiple modifications, double lumen tubes are still the most widely used devices for achieving safe one-lung ventilation. So in this picture, we can see the right-sided and the left-sided Robert Shaw double lumen tube. And we can see that the bronchial balloon of the right-sided double lumen tube has a slit designed to ventilate the right upper lobe. So actually, the double lumen tube is a bifurcated tube with separate tracheal and endobronchial lumens that can be used to ventilate either lung independently. The tracheal lumen is designed to terminate above the carina, while the bronchial balloon is angled to fit into the appropriate mainstem bronchus. The bronchial cuff and its pilot balloon inflation line is usually colored blue for easy identification. So these are the main features of the modern double lumen tube. We can see that there are 2 cuffs: a tracheal cuff, which is transparent or colorless, and a bronchial cuff, which is blue in color. And proximally, there is an adapter. And also we have the pilot bronchial balloon and tracheal balloon. Suction catheters can also be supplied with the package. What about the differences between the right and left-sided double lumen tubes? Right and left-sided double lumen tubes differ in their basic design because of the crucial anatomical differences between the right and left mainstem bronchi. The right main bronchus is shorter, straighter, and wider than the left main bronchus. Additionally, the right upper lobe bronchus takeoff is very close to the origin of the right mainstem bronchus. So if we look at this picture, which demonstrates the anatomy of the tracheobronchial tree, we can see that the right main bronchus is wider and shorter and more in line with the trachea compared to the left mainstem bronchus, and the origin of the right upper lobe is very close to the carina. It is for these reasons that right-sided double lumen tubes have a modified cuff and side opening called Murphy's eye in the endobronchial tube to allow ventilation of the right upper lobe. So this is the distal end of the right-sided double lumen tube, which is characterized by an oblique cuff and also an opening called Murphy's eye, designed for the ventilation of the right upper lobe. And this picture shows both the right-sided and the left-sided double lumen tube, showing the differences. The left bronchial balloon is rounded without a slit, while the right-sided bronchial balloon is oblique and has a slit or Murphy's eye for the ventilation of the right upper lobe. First of all, when we have a patient in need of double lumen endotracheal intubation, we should answer the following questions. The first question, what side of double lumen tube is needed? Although most elective thoracic procedures can be successfully managed with a left-sided double lumen tube, there are some specific indications for use of a right-sided double lumen tube. Now, it is obvious from the previous discussion that a placement of left-sided double lumen tube is easier than a right-sided double lumen tube because of the problem of ventilation of the right upper lobe. Therefore, most doctors actually use a double lumen tube, which is left-sided, regardless the type of the thoracotomy, whether it is right thoracotomy or left thoracotomy. And many residents in thoracic anesthesia state that they have never placed a right-sided double lumen tube. However, there are certain situations in which the placement of right-sided double lumen tube is mandatory, although it is difficult in a practice. For example, in left-sided thoracoscopic surgery, in left-sided thoracoscopic surgery, the surgeon prefers to place right-sided double lumen tube because the presence of left-sided double lumen tube in the bronchus make mobilization of the bronchus a bit difficult. So these are the indications for a right-sided double lumen tube. Surgery involving the left main bronchus, such as left pneumonectomy, left lung transplant, left tracheobronchial disruption, left-sided thoracoscopic surgery. One comment that in left pneumonectomy, actually, a left-sided double lumen tube can be used, and when the surgeon reaches the stage of division of the bronchus, the tube can be withdrawn to a level above the carina to complete the operation. The second indications for a right-sided double lumen tube is the distorted anatomy of left main bronchus, such as in aneurysm of the descending thoracic aorta, and when there's a tumor compressing the left main bronchus. The second question, what size of double lumen tube do we choose for our patient? Adult double lumen tubes commonly come in sizes 35, 37, 39, and 41 French. The French scale is the external diameter of the tracheal segment in millimeters multiplied by 3. A properly sized double lumen tube is one that passes easily through the glottis and advances without resistance within the trachea, with the bronchial component passing into the intended bronchus without difficulty. A traditional approach would be to use 37 and 39 French double lumen tubes for average sized female and male patients, respectively. A size up or down is used for larger and smaller patients, respectively. So in practice, two sizes should be available, 37 for females and 39 for males. The most accurate method of selecting the size of the double lumen tube depends on measurements of the left main stem bronchial diameter from a CT scan. The third question, how is the double lumen tube is inserted? First of all, check the integrity of the tracheal and bronchial cuffs. Lubricate the outside of the double lumen tube. Lubricate and insert an intubating stellate into the endobronchial lumen before insertion. The stellate can be pre-shaped to aid placement of the double lumen tube. Perform direct laryngoscopy and visualize the glottis. Advance the double lumen tube till the endobronchial cuff has passed beyond the vocal cords, and then remove the stellate. Rotate the double lumen tube 90 degrees clockwise or anti-clockwise, depending on the side of the double lumen tube placement. Pass the tracheal cuff beyond the glottis until resistance is encountered. The depth of insertion of the double lumen tube correlates to the height of an average size patient and is given by the formula 12 plus patient height divided by 10 in centimeters measured at the teeth. Now, the following slide shows a video, 4 minutes video, which demonstrates the procedure of insertion of a double lumen tube and the confirmation of the proper position with the technique of sequential clamping and auscultation, as well as the use of fiber optic bronchoscope.
Okay, today we're going to go over double lumen tube placement, and the technique that I'm going to show you is direct laryngoscopy. So when you're going to insert a double lumen tube, you go ahead and do laryngoscopy like normal. Then when you're ready to insert the double lumen tube, you're going to want the bronchial lumen in front of the tracheal lumen. So then when we get our view, we go until this bronchial lumen gets to the level of the vocal cords. And then two things need to happen. We need to rotate this tube 90 degrees to the left and have an assistant remove this stylet for us as we advance into the trachea. On the view from the inside, you can see that once this blue cuff is at the level of the cords, we go ahead and rotate that tube to the left and have an assistant remove the stylet as we advance into the trachea. Once this double lumen tube is in, we're going to need to ventilate the patient, so we need our adapter here. So we hook up our adapter, then we inflate our cuffs here. So we put some air in the tracheal cuff, and then we put some air in the bronchial cuff, and you really only want to put 2 to 3 cc's of air in this bronchial cuff. Now it's time to ventilate the patient. And once you can verify that you can ventilate the patient, we need to check to see whether or not this is correctly placed. So the first method is auscultation, and so to do that you need to clamp one of the lumens. So here I'm going to clamp the bronchial lumen. So if this is correctly placed, I should only hear breath sounds on the right side. And you can see that that's true. I can only hear it on the right side. And then if I want to go ahead and clamp the tracheal lumen, I should only hear breath sounds on the left side, and that's the case. The second way to verify correct placement of the double lumen tube is to use a fiber optic bronchoscope. And the best way to do that is to open this cap to the tracheal lumen, and we're going to insert this scope down into the tracheal lumen and look at the level of the carina. So as we're advancing this scope down the tracheal lumen, we're eventually going to come to the carina. And it looks like that's carina right there. We can see that the right main stem is open, and you can see that blue cuff right there occluding the left main stem. So that is perfect placement of a left double lumen tube.
Alright, so the other method of placing a double lumen tube is by using fiber optic bronchoscope. When you place the double lumen tube, you want to place the fiber optic scope through the bronchial lumen. Once at the uvula, advance the scope. Once you see the epiglottis, flex your tip upward and advance towards the glottic opening. Down into the left main stem. At this point, you can advance the tube over the scope into the left bronchus. So once the tube is advanced, I'm going to back out of the bronchial lumen and go down the tracheal lumen. Alright, going down the tracheal lumen, I will see that the cuff is off, the bronchial cuff is off to the left, and that it is not herniating over the carina. The last method I want to show you in placing a double lumen tube is a combination of direct laryngoscopy along with fiber optics. So go ahead and perform your laryngoscopy like normal and insert your double lumen tube in the same manner to the level of the cords. At this moment, you want to have an assistant pull the stylet and hold the tube. You can remove your blade at that point and insert the fiber optic scope through the bronchial lumen. Once I'm in the bronchial lumen, I advance the fiber optic scope past the tube itself. When you exit the tube, you should see the carina in front of you. Advance and direct the scope into the left bronchus. At this point, your assistant can advance the tube over the fiber optic scope into the left bronchus.
And auscultation method. Step 1, inflate the tracheal cuff with the minimal volume to seal glottic air leak. Perform positive pressure ventilation and auscultate to confirm bilateral air entry. Number 2, step 2, clamp the tracheal limb of the breathing circuit connector and disconnect this from the tracheal lumen of the double lumen tube. Inflate the bronchial cuff with 1 to 3 ml and ventilate through the bronchial lumen. Auscultate to confirm unilateral ventilation and no audible air leak. Step 3, release the tracheal lumen clamp and close the port. Auscultate to confirm resumption of bilateral air entry. Now, these 3 steps are nicely demonstrated in the video. Fiber optic bronchoscopy confirmation. While the sequential clamping and auscultation technique described before is usually sufficient to confirm appropriate position of left-sided double lumen tubes, fiber optic bronchoscopy is usually used to confirm the same. And for right-sided double lumen tubes, fiber optic bronchoscope confirmation is essential for accurate placement. For left-sided double lumen tubes, insert the fiber optic bronchoscope through the tracheal lumen and visualize the carina. Identify the blue-colored endobronchial cuff as a thin crest within the left main bronchus, but not herniating over the carina after inflation. So in this picture, we show a properly placed left-sided double lumen tube with a bronchial balloon in the left main stem bronchus, and the fiber optic bronchoscope shows that the bronchial balloon is just distal to the carina. And here, for right-sided double lumen tubes, in addition to the previous steps, insert the fiber optic bronchoscope through the endobronchial lumen and ensure that the Murphy's eye is aligned with the right upper lobe bronchus. So in this picture, we can see a properly positioned right-sided double lumen tube with the Murphy's eye against the orifice of the right upper lobe, and the fiber optic bronchoscope shows that the bronchial balloon is just distal to the carina. Now, what are the problems related to the use of double lumen tubes? Number one, malposition. This is the most common problem encountered with the use of double lumen tubes. While small malpositions are clinically insignificant, a majorly malpositioned double lumen tube may partially collapse the ventilated lung or fail to permit collapse of the intended lung, causing hypoxemia and inadequate surgical access. Common causes of malposition include dislodgement of the endobronchial cuff because of overinflation, extension or flexion of the head and neck during or after patient positioning, and surgical manipulation of the bronchus. Now, in this picture, we can see properly seated right-sided double lumen tube confirmed by fiber optic bronchoscopy, while here we can see a low-seated right-sided double lumen tube in which the bronchial balloon is actually blocking the orifice of the right upper lobe. And here you can see a low-placed left-side double lumen tube in which the bronchial balloon is blocking the left upper lobe, and there is only a possibility of ventilation of the left lower lobe. And here you can see a high-placed left-side double lumen tube in which the tube is positioned above the carina. Again, here we can see a high-placed left-side double lumen tube with bronchial balloon herniating over the carina. And here, sometimes a left-side double lumen tube is improperly or is mistakenly advanced into the right main bronchus, resulting in a blockage of the orifice of the right upper lobe. The other problems related to the use of double lumen tube are airway trauma and tension pneumothorax. Airway trauma, an oversized double lumen tube or an undersized double lumen tube that has migrated distally can rupture the membranous portion of the trachea or bronchus. Iatrogenic airway trauma can present as unexplained air leaks, subcutaneous emphysema, massive bleed into the double lumen tube lumen, or protrusion of the endobronchial or endotracheal cuff into the surgical field. The last problem is tension pneumothorax in the dependent lung during one lung ventilation, caused by high ventilating pressures or large tidal volumes, especially in patients with pre-existing emphysematous lung disease. So this picture shows a bronchial rupture due to the use of a double lumen tube. Take-home messages of our lecture: double lumen endotracheal tubes are the most commonly used devices for lung isolation. Routinely, left-sided double lumen tube is used for most thoracic surgeries. Right-sided double lumen tube use is reserved for special situations due to the difficulty of proper placement. A fiber optic bronchoscope is essential to aid placement, confirm position, and diagnose problems that arise with the use of double lumen tubes. And this is a list of bibliography used in the preparation of the lecture, which consists of an article, a journal article, beside a few YouTube videos. And with this nice photograph of old Baghdad, I would like to thank you for watching and listening to the lecture. This is Professor Abdulsalam Yassin Taha signing off from the College of Medicine, University of Sulaimani.